Let us pray.
Okay, thank you.
Almighty God, we thank you for this moment that we are here, even to share information on what we have. Lord, we pray that you may guide this session. We pray for uninterrupted internet. We pray for participants that they are going to learn from what we are going to share. May you give us wisdom, give us the right words to use, O Lord. Help us even as we continue sharing information, that you may also continue teaching us and expounding our knowledge, O Lord. And even as we receive from other people, Lord, may we apply it to other, may we freely share. In Jesus' name we pray. Amen.
Amen. Thank you so much, Hadija. Now, because of the interest of time, I'm sure the rest of the attendees will be joining in shortly. Basically, the purpose of this meeting is just to do a dry run to be sure that we are ready for the program, to project the slides and ensure also that each and every one of us is audible in good time to be able to do the presentation. So we'll start with the first presenter, Dr. Angeline Chiptucci. Can you hear me? Dr. Angeline?
I do.
Okay, good morning.
Good morning, Doris and everyone else.
Good morning. Dr. Angeline, would you mind just introducing yourself briefly so that Mbao can also pick your bio for purposes of introducing you as we start off?
Okay. Good morning once more. My name is Angeline Chiptucci. I'm an infectious disease specialist. I teach at the University of Nairobi School of Nursing Sciences. I've been part of the module writers for this infection prevention. And I think in the past we've facilitated together with Doris and the team. So thank you so much. Welcome.
Okay, thank you so much, Dr. Angeline. Over to you, Hadija Lele.
Okay, good morning. My name is Hadija Lele. I have my background. My training is in environmental health and safety. In the Ministry of Health, Department of Public Health, under the Division of Occupational Health and Safety. That has been my area of specialty. I also participated in the development of this module.
Okay, thank you so much, Hadija Lele. Jemima Katama, good morning and you're welcome. Over to you.
Good morning, everybody. I'm Jemima Katama. I work at Kenyatta National Hospital. I'm the lead infection control coordinator. I'm also the secretary for the Infection Control Nurses Chapter, which is under an NNK. I've also participated in the development of the training curriculum. Thank you.
Okay, thank you so much, Jemima. Thank you so much for joining us. And my name is Doris Botter. I work for USA DEMTAPS. I coordinate the infection prevention and control activities, providing technical assistance to the Ministry of Health and professional associations. So we've also been joined by Mbao Getao, who is our host this morning. Thank you so much, Mbao, for the coordination and to ensure that we have this up and running. Kindly, if you could introduce yourself.
Good morning, ladies. Yes, it's ladies, I'm correct. My name is Mbao Getao. I'm a communication and events lead at the Pharmaceutical Society of Kenya, the umbrella body mandated to represent all pharmacy, pharma and allied members in the country. And one of our mandates is to ensure that we get our members up to date in matters COVID, in matters infection prevention control. I'm a pharmacy graduate. So this is also an area that probably is of my interest with my background in training. And I'm honored to be part of this panel where the two that gender role has already been surpassed. the truth and gender rule has already been surpassed. It's okay. So I hope for better. I hope for a good and interactive session. I can see that my members 280 have registered them. Let me hope that I will be able to get all the 280 in attendance for today. And may we have a great and a wonderful webinar. Pleasure meeting you all. Asanteni.
Thank you so much. It's a pleasure. I'm seeing we've also been joined by Peter Karegwa. Peter Karegwa is one of the facilitators for today, for tomorrow's webinar. Peter, you're welcome. You want to say hi?
Hi, everyone. Thank you very much.
Thank you so much for joining in, Karegwa, and for your commitment. Peter comes from the Kenya Pharmaceutical Association, KPA. I think I'm still trying to get into terms with the different abbreviations. So thank you so much for joining in. And Karegwa, you're welcome to share the link with the KPA members because this is our pharmaceutical agenda. They're very much welcome. So if you could allow me to just project the program for the day so that we can see who is presenting what. And I think after that we'll be good to go. In the meantime, Dr. Angeline, would you want to project from your end? Dr. Angeline, would you want to project from your end?
Yes, Doris, it would be easier for me to follow if I am presenting the presentation.
Okay, thank you so much. So I've projected the presentation. You'll be given about 30 minutes. Are we able to see the program from your end?
Yeah, quite clear.
Okay, so we'll start off. We'll start off with Mr. Mbao Getao from PSK taking us through the welcoming open remarks and introduction of facilitators. Then Dr. Angeline will pick up. So Mbao, you'll introduce Dr. Angeline so that she can start on the introduction to IPC in healthcare settings. Then I'll take up on management and coordination of infection prevention and control. And we'll have hand hygiene in healthcare facilities. Jemima Katama, would you want to project from your end as well? And have you seen the presentation?
I want to project. I will project from my side.
Okay, thank you. Then that will be followed by overview of occupational health and safety by Hadija Lele. Hadija, would you want to project from your end?
No, project for me.
Okay, I will project for you. Then it will be followed by plenary session for about 5 minutes, and that will be coordinated by Mbao Gitao from PSK and myself. So normally this session takes about, let's say 5 minutes at most, because the program is quite comprehensive. So what happens is that we don't pick any questions until all the presentations have been done. I think that will be good to go. And then we have to control how the questions come in. So I will request one person to be reading the question and answer session, just to be able to see whether there are any questions that I have left out. And then we'll probably open up to the platform and give 1 or 2 people to ask questions. So please be on standby in case any of the questions is directed to the presentation you've done, or if you feel that, you really have the answer to the question asked, please feel free to respond to it as well. Then it's going to be followed by the closing remark by Dr. Anis Rahentula from PSK. So that is it for today. Yes, sir.
It's Rahim. M.
How did I miss that?
M. Anis Rahim. It's A Anis. Then R-E-H-M. Rahim. The name Rahintula. It's M. Yes.
Apologies for that.
So probably for continuity, up there it's Mbao Getao. So here down here, just bring it to Mbao Getao at the plenary session.
Okay.
Yes.
Start with Mbao.
Yes.
Okay, thank you so much, Mbao, for that. So I hope we are all good. Any question, input?
probably we can see those who are going to share from their end. We can try see them if they're able to share, so that they're able to. They don't have a hitch with probably the PowerPoint. It will be normal.
Okay. Okay. So we can start with Dr. Angeline. Please try to project from your end. As I stop sharing. Dr. Angeline?
Did we change the presentation or is still the same one as it was?
It's still the same. We haven't changed the presentation.
Okay.
Yeah. Then Jemima, please prepare with your presentation as well.
I'm ready.
Okay, maybe you can project yours as you wait for Dr. Angeline.
Yes.
Or Dr.
Angeline has already done it.
Mm-hmm.
It's okay.
So Dr. Angeline, please go to slide 1. And then please put it in PowerPoint mode.
So this is the module 1. Introduction to infection prevention control in healthcare settings. So we have the second slide, which gives us the learning outcomes, the definition of terms, then introduction to give us the background on our settings and in relationship to the outside world. Then we have continuation on introduction. We have the rationale for IPC, modes of infection transmission, IPC practices, standard precautions continued.
Okay, Doc, I think because of the interest of time.
Yes, I want
to.
Okay.
Yeah, I think you are good. We are able to see the projections very well and also the transitioning.
Okay.
And you're also audible. Thank you so very much.
So I stop sharing.
Yes, kindly. Jemima, kindly project from your end as well.
Can you see my slides?
Yes, yes.
Yeah, clear.
Mm-hmm. Okay.
I think that's okay.
Yeah, that's okay. Thank you. Thank you so very much.
Welcome.
So allow me to project from my end as well, just to be sure that we are good to go. And I'll start with Hadija's presentation. Okay, are we able to see?
Yes, we can see.
Okay. Am I moving?
Yes.
Yes, you are.
Okay, Adija, you okay with the writings? They are visible?
Yeah, they are good.
Okay. And I will project my presentation on coordination and management of IPC. Are we able to see?
Yeah.
Okay. So I think we are prepared and we are good to go.
Yeah.
So Mbao, is that okay?
Fine from my end. So attendees, the attendees have already begun coming in.
Okay.
So So what we do is we can have the program as the first page. Eh?
Okay.
Yes. Perfectly well.
So, Bao, you'll start us off when you are ready.
Absolutely, absolutely.
Okay, thank you so much.
Good morning, distinguished members of the Pharmaceutical Society of Kenya. Good morning, our esteemed and respected panelists. Good morning, other allied healthcare professionals who have joined us this morning for this wonderful learning opportunity. Ladies and gentlemen, welcome to this session on training on infection prevention and control. It is a partnership between the Pharmaceutical Society of Kenya and USAID MTAPs. Ladies and gentlemen, just a few ground rules probably. Let me allow our members. We are currently at 24 attendees, 25 attendees, and thank you very much for all members who have joined in. I can see a distinguished seniors in the profession, Dr. Lily Kimuhu. I can see Dr. Eric Gwentai, Dr. Catherine Joroge, and Dr. Munywa Gashohi. Thank you very much for joining us this wonderful morning, senior esteemed members of the professional society. I will allow us probably the next 3 to 5 minutes to allow in members to at least have a quorum of at least 50 members. I know members are joining in now. So ladies and gentlemen, be patient. Let's give them at least 5 minutes of our time. It's now 11:01. By 11:05, we shall have kicked off officially. So kindly bear with us for that, ladies and gentlemen. Thank you very much for coming in. And those who are already into the meeting, kindly ensure that you have subscribed on the PPB portal for the event today. Kindly ensure that you've subscribed on the PPB portal for the event today. Dr. Beryl Nganga, Belinda Nganga, thank you very much for joining. Dr. Bina Patel, Asante. Asante sana for joining us today. We begin at exactly once attendees get to 50 or it gets to 11:05, whichever comes first, we go ahead. But thank you very much for joining us in today. Dr. Marilyn Ndegwa, asanteni sana kwa kuja. Dr. Netia, asante sana kwa kuweza kujiunga nasi siku ya leo. Let's allow our members to join in. Let me be able to fast track their access, and we are going to be able to begin right on time. Asanteni.
Hello, hi.
Is that link that is on the whatever on the what do you call that? The whatever the flyer that you sent?
Yes.
But that link is not active at that flyer.
Okay.
Would you mind you said for group the one that is active so that can get?
Okay, let me ask them to send me because I'm not so sure whether if I send them what we were sent, they will all go to
to join me the one that we were sent on the mail. But it's like it was meant for the panelists.
Yes.
So when
once again, distinguished members of the profession, seniors, respected seniors of the Pharmaceutical Society of Kenya. I can see some are here. Dr. Munyo Gashuhi is here. Dr. Ben Ogonji from Siaya is here. I can see Dr. Eric Guantai is here. Dr. Esbon Njau is here. Thank you very much, Dr. from all the way from Kabarak. Dr. Lily Kimuhu, asanteni sana for joining us, and Dr. Isaac Gishinga, asanteni sana for joining us. The pharmaceutical technologists, allied healthcare professionals, and our esteemed panelists this morning, Hamjambo. Welcome to today's webinar on infection prevention and control. It is in partnership with the Pharmaceutical Society of Kenya and USAID MTAPS, that is USAID Medicines, Technologies, and Pharmaceutical Services Program. This morning we are delighted to have panelists from the web of the healthcare professionals. So, ladies and gentlemen, I'll just give you a few ground rules. First, you all remain muted during this webinar. Second, we are recording the webinar. We shall later on share this recording on YouTube, on our YouTube page. Our YouTube page is the Pharmaceutical Society of Kenya. Thirdly is members, you are requested to subscribe on the PPB portal for today's webinar. It is already up. It is already on the PPB portal. And CPD tokens are only issued to up-to-date Pharmaceutical Society of Kenya members. So, esteemed member, if you've not updated your membership, I will be sending you reminder messages for the contacts you're supposed to ensure that you update your membership with. Otherwise, asanteni sana, asanteni kwa kuja. Let us now go to what has woken up, that has kept us waiting this morning. Without further much ado, ladies and gentlemen, I will want to introduce our first speaker. And before I introduce the first speaker, I will introduce what and why are we here. Currently, everybody is up to date with the reason to why what 2020 is, and you have been seeing probably images showing that 2020 is all about the mask. 2021, we are headed to the vaccine stage. Yesterday, with Moderna reporting 100%. Moderna reporting 100% efficacy on their vaccine. So, ladies and gentlemen, I will introduce our first speaker. And our first speaker for today is Dr. Angeline, Dr. Angeline Chiptucci. She is an infectious disease specialist. She is a lecturer at the University of Nairobi School of Nursing, and she has been part of the writers of this module with USAID MTAPS and MOH for the infection prevention and control during this COVID era. So, Dr. Angeline Chiptucci, if you're with us, I would allow you to share your kindly. I will allow you to share your screen, Dr. Angeline. Dr. Can you hear me?
Good morning, everyone.
Good morning, Dr. Karibu sana, Dr.
Welcome to this presentation. The infection prevention control. Okay, thank you. So we have about 30 minutes to go through this. We already know the importance as to why we are revisiting IPC in a serious manner. Module 1 just introduces us on what we expect at the end of the module. We would be able to define IPC and components of IPC. We'll be able to identify IPC, as known to all of us, is that process that includes policies, procedures, and activities that are designed to prevent spread of infections in the healthcare settings and also in the community. And we often come across healthcare-associated infections, and these are infections acquired while delivering healthcare services. or while receiving treatment, and was not incubating at the time of admission. Often it appears 48 hours after admission, while visiting the healthcare setting, or within 30 days after discharge for surgical site infections. We also have this term community-acquired infections, and these are infections contracted outside the healthcare facility. They could also be present at the time of admission of a client. The healthcare infections, associated infections, at any one time, up to 7% of patients in developed world and 10% in developing countries will acquire at least one hospital-acquired infections or healthcare-acquired infections. So this according to WHO. So these are problems that is there with us. And in Kenya, the actual burden of HIs has not been accurately quantified, but is estimated to account for about 10 to 25% of hospital admissions. And these infections can be spread to other patients and even healthcare workers, or even to the community, if proper infection prevention control and wash measures are not implemented. However, a large percentage of healthcare-associated infections are preventable through effective infection prevention and control measures. The international health regulations give significant weight to IPC as a central strategy for dealing with public health threats of international concern. And such strategies have been tested in recent times based on infectious diseases such as the current coronavirus infection, COVID-19, the global outbreak. We had the recent Ebola virus disease outbreak in West Africa, as well as the severe respiratory syndromes. So this demonstrates the key role of IPC strategies in controlling these infectious conditions. So the rationale for infection prevention and control is that we work in healthcare facilities.
Excuse me, Dr. Angeline.
And these are settings that potentially source of transmission of
Dr. Angeline, can you hear me?
We have patients who infection days meet to other patients and those health workers. Yes, Doris?
Hello, Dr. Angeline. Apologies for
yes, Doris?
Apologies for interrupting. It seems your network is quite unstable.
Okay.
Yeah, we are losing you.
Okay.
Yeah, but we can hear you now. Thank you.
Can I change? Let me change the connection. Hello?
Yes, we can hear you now, Dr.
Yes,
we can hear you. Thank you so much, Dr. Angeline.
I started introduction again?
Yes, please.
Okay, sorry for that. So we are beginning at the first module, which introduces all of us to IPC. And we are trying to get the outcomes, expected outcomes of this module. So at the end of the day, we'd expect that we all are reminded of what IPC is and in association with healthcare infections. We'll be able to describe the components of IPC. We'd also be able to identify modes of infection of transmission. We'd also be able to explain the benefits of adherence to IPC practices. And we define the terms here, what IPC means, what HAIs, as well as community transmission is. And I began here by giving introduction on the prevalence of HAIs, which is about 7% in the developed world and about 10% in the developing countries. In Kenya, we do not have specific data, but we have an account of about 10 to 25% of hospital admissions ending up with hospital-acquired infections. And these infections can be spread from other patients to healthcare workers and vice versa, and also in the community if IPC and WASH measures are not adhered to. And the beauty is a large percentage of these HAIs are preventable through effective infection prevention and control measures. We went ahead with international health regulations. They give significant weight to IPC as a central strategy for dealing with public health threats of international concern. Today, we are talking of coronavirus. Yesteryears, we had Ebola outbreak in West Africa and the SARS. This further demonstrates the key role of IPC strategies. We have the rationale for IPC. One is that the healthcare facilities where we work in, most of us, are potentially major sources of transmission of HAIs. They provide an enabling environment for the spread of these infections. So we have the patients who have infections. They can transmit the positive agents to other patients and also healthcare workers. Three, we have sick patients who are more susceptible to these infections because they are immunosuppressed. And fourthly, the invasive procedures that most of these patients are exposed to, they increase their risk of acquiring hospital-acquired infections. There are several modes of infection transmission. We have the airborne spread, we have the droplets, we have contact, we have those agents transmitted through a vehicle of transmission, which could be food, contaminated food, water, or air. And we also have those which are transmitted through vectors, where some other organisms that act in the middle, whether they are insects, can support this, the survival of the pathogen and transmit them to susceptible hosts through bites. We have IPC practices that have been categorized into two. We have the standard precautions, which are the universal standard measures, and we have additional precautions that are tailor-made based on the nature of transmission of an agent. We have the standard precautions, which are sets of infection control measures. They are used to prevent transmission of these diseases that can be acquired through blood, through body fluids, or through non-intact skin, like rashes and mucous membranes. We also have these measures that are used when providing care to all individuals, whether known or not known to have infectious diseases. And the additional measures come in as a second tier of basic infection control and are to be used in addition to standard precautions for patients who may be infected or colonized with certain infectious agents, where additional precautions are required. For example, the coronavirus infection. For standard precautions, we have hand hygiene as the leading intervention, or rather component. And hand hygiene refers to the washing of the hands, both with soap and water, or using alternative means of disinfection like the alcohol-based hand rubs. We also have the use of personal protective equipment. They are worn by healthcare workers to protect themselves and the patients from potential hazards. So these ones run from the masks, from the gloves, from the shields, the aprons, and many others. We also have prevention of needle stick and injuries from other sharp instruments. These interventions prevent healthcare workers exposure from blood-borne pathogens. We have respiratory hygiene and cough etiquettes, and these include series of actions that are to be observed by individuals when they are coughing or sneezing, and they are designed to reduce the spread of respiratory illnesses to others. Covering of the mouth, using tissues and disposing them immediately, washing hands, or using sanitizer immediately. We also have environmental cleaning, This is an essential component of all hospital settings where clients are admitted or clients come in contact with the common waiting areas and other areas where clients have potentially contaminated the services. We have common areas like the doorknobs, sinks, toilets, and other services with close proximity to clients. The requirement is proper disinfection every other time. We have management of linen. This is a prerequisite in inpatient settings. Used linen is a potential source of infection transmission because of the shared use. So there are those standard measures that include sorting, sluicing, disinfecting them, drying them well, and ensuring that they are free from pathogens. Then the major health issue, the management of healthcare waste. We have a lot of waste generated through healthcare service provision, most of which are highly infectious, and they need to be sorted and disposed appropriately. So each of the categories need to be disposed of according to the relevant healthcare waste management protocols. We have the patient equipment, especially those which are used in surgery, surgical interventions, surgery. They need to be recleaned well, decontaminated, disinfected, and sterilized, and stored safely to ensure that subsequent use will not expose any patient to the risk of infection. Then we have the specific transmission-based infection prevention precautions. For airborne precautions, these are applied when we have patients who are known or suspected to have serious illnesses that are transmitted by airborne particles 5 micrometers or less in size, and that can remain contagious in the air for several hours. So for a long time, we've always dealt with Mycobacterium tuberculosis, TB. But today we also acknowledge the COVID-19 that is also transmitted through airborne means. So the components of care include that patient placement and transportation should be noted, and patients should be cared for in a private room with door kept closed. The room air should be exhausted to the outside. So there's need to have negative air pressure within the room where the patient is held, and use of fans or another filtration system for the air that is leaving the room. For the respiratory protection for healthcare providers, then this is where we need appropriate masks when caring for these patients. For tuberculosis, for example, there's need to use the respiratory mask N95. And patients should be on surgical masks. This ensures that there is minimized transmission. For droplet precautions, these precautions reduce the risk for transmitting pathogens spread wholly or partially by droplets larger than 5 micrometers in size. So it's slightly simpler than airborne precautions because particles remain in the air for a short time and travel only a few feet. So the typical example here is the COVID-19. But in the past, we have had mumps influenza pertussis as commonly spread through droplet means, or droplets, particles in the droplets. We have components of droplet precautions that include patient placement, keeping a patient at least a meter distance between each other, and ensuring that if possible, they are cared for in a private room. And the healthcare provider should wear masks while caring for the patient all the time. For contact precautions, this is applicable when patients are known or suspected to have serious illnesses that are easily transmitted by different patient contact or by contact with items in the patient's room. So effective in preventing infection from patients with wet or draining infections that might be contagious. So for example, those with abscesses, patients with blisters, those with herpes zoster, impetigo, conjunctivitis, scabies, lice, and wound infections. So for contact precautions, we need to ensure that patients are placed and transported in a manner that they don't come in contact with others. And there's need to ensure hand hygiene and use of PPEs by the staff. And the equipment that are used by these patients should be processed adequately before they are shared out for use with other cases. So having discussed the precautions, we know the benefits of adherence to Ipc practices that include reduction of hospital-acquired infections. And when we do that or achieve that, that means we're having quality healthcare and protecting the community from infections. Minimizing the cost of treatment and length of patient hospital stay. Hospital-acquired infections require prolonged treatment with costly second-line and third-line antibiotics. And we also prevent occurrence of infections from multi-drug resistant organisms. These organisms are bred easily in the healthcare settings. We also promote patient and healthcare worker safety and reduce occupational hazards associated with hospital-acquired infections and community-acquired infections. When we talk about occupational hazards, corona infection is one of those that we see today. It's a real health hazard for the healthcare workers. It also helps us to reduce cases of litigation against healthcare facilities and institutions. If there is clear evidence that a patient has acquired a secondary infection while hospitalized that has costed them a lot of money and pain in terms of the morbidity, then the patient can easily litigate and be paid damages for that exposure. Here we just have a case scenario that helps us to put in perspective Ipc. And Mr. X was admitted for abdominal surgery. This is just like this scenario. After 3 days post-surgery, the following findings were observed. Found that the patient's abdominal incision had purulent drainage and slight erythema. Patient had a temperature of 40 degrees Celsius. Lab culture showed Enteropacter species and E. coli colonization. And the patient had an extended stay for treatment of septicemia in the hospital for another 7 days. So upon discharge, this patient was asked to, or upon discharge, the patient paid 3 million shillings. But the patient was able to turn around and sue the facility, for a compensation of 3 million. So meaning he spent a lot of money. It may not be 3 million, but the pain of extended hospitalization and the cost of care. So hospital-acquired infections are very costly, hence prevention is the best way to go. So from that case, HAIs are very costly, and we can have several reasons as to why a patient may develop surgical site infection. It is possible to minimize the risk if we observe Ipc practices as prescribed. In summary, we are saying that Ipc is very important. It prevents harm to patients, prevents harm to health workers, and even visitors to come in to visit these patients in the healthcare facilities. It's a fundamental initiative to achieve quality care, to achieve patient safety, and for health security and the reduction of healthcare associated infections. And ultimately, the overuse of antimicrobial agents, which leads to antimicrobial resistance. So that is the background, the introduction to these Ipc modules, and we have a few references therein. Thank you so much for listening.
Asante sana, Daktari, for taking us through that. So before we go to the question and answer, Before we go to the question and answer, I will ask us to proceed probably to our next speaker. We proceed to our next speaker so that we are able to catch up and be on time. And our next speaker for the day, is none other than Doris Botter. Doris Botter is the Technical Advisor, Global Health Systems Innovation, Management Sciences for Health. And Doris Botter is going to take us through. Doris Botter will be taking us through for the next 20 minutes. She's going to take us through for the next 20 minutes, ladies and gentlemen. And without further much ado, let me welcome Doris. Doris, are you with us?
Yes, I'm with you, Bao.
Perfectly well in order. So without further much ado, this is your floor. The floor is yours, Doris. Kindly take us through our next session.
Okay, thank you so much, Bao, for the coordination and for the warm welcome. Good morning, everybody, and thank you, PSK, for giving us this opportunity. Like Bao has said, my name is Doris Botter. I work for USA MTAPS, which is a program within Management Sciences for Health. So today, I'll give us a presentation on management and coordination of infection prevention and control. And Dr. Angeline has just given us the foundation of what we'll be talking about today and tomorrow. And so there's a national IPC lead from Africa who gave a statement sometimes last year about his implementation when it comes to infection prevention and control. And what he noted is that we will not win the fight combating healthcare-associated infections and antimicrobial resistance without infection prevention and control. It's an effective IPC action at the point of care. It is not possible without an integrated IPC program and dedicated IPC champions. And whenever we could, the IPC national lead from Africa and their colleagues at every relevant Ministry of Health meeting, they would present IPC and advocated for its importance until they gained leadership support and grew from there. So what is the take-home message from this narrative? It is that we need to advocate for IPC activities at every given meeting. We need to be champions of infection prevention and control so that we can be able to grow and fight the healthcare-associated infections. Dr. Angeline from the previous presentation has alluded that healthcare-associated infections are very expensive. And right now, patients and healthcare workers know their right when they get infected in hospitals. So the expected learning outcome of this presentation basically is to describe the structure for management and coordination of IPC at different levels of healthcare delivery. We're also going to identify the existing IPC policy and guidelines and describe the minimum requirements for IPC implementation at different levels. And finally, we're also going to describe the monitoring and evaluation of IPC programs. But before we do that, it would be good for us to define a couple of terms because they're going to be recurring in most of the presentations. When we talk about IPC minimum requirements, these are IPC standards that should be put in place at both national and health facility level to provide minimum protection and safety to both the patients, healthcare workers, and the visitors. When we talk about the Ipc Focal Point, who is also called the IPC coordinator, this is a professional. They could be a nurse, a doctor, or any other health cadre that is appointed to be in charge of IPC at the national or facility level, and who has a specific training on IPC, leading to a certificate, a diploma, or even a degree. Then for the IPC committee, these are multidisciplinary groups with interested stakeholders across the facility, which interacts with and advises the IPC team and also on the hospital on how best to implement IPC activities. So as we continue with this presentation, I'll be alluding so much into this, and it is good for us to be able to understand what these terms mean. Now, for Ipc governance structures, they are established with an aim of facilitating coordination of IPC programs programs across the different levels of healthcare. And at this point, I'll be talking so much about the national, then I'll go to the county, the sub-county, and the facility level. And by developing and establishing an IPC program, this ensures that leadership and the right technical expertise is in place to support all IPC activities. And so the IPC national program supports the prevention of avoidable infections and saves lives. Basically, effective IPC programs leads to more than a 30% reduction in healthcare associated infection rates. And so the other day we were discussing about hand hygiene, and the next presenter, Jemima, is going to be talking about that. For example, hand hygiene is one of the components of infection prevention and control. And if you implement proper hand hygiene programs in a health facility, you are able to reduce about 80% of healthcare associated infections. And so this is a very important key component that we need to really take seriously as a team. Now, I had mentioned that we'll be talking about the institutional governance structures at the national, the county level, and even at the facility level. And so at the national level, we have what we call the National IPC Adversary Committee. We also have the National IPC Technical Working Group, and we have the Ministry of Health IPC program. At the county level, we have what we call the County Infection Prevention and Control Advisory Committee. At the sub-county level, we have the sub-county IPC coordination. Then at the hospital level, that is from level 4 to 6, we have the IPC committees. At the primary facility level, that is the level 2 and level 3, we have IPC coordination. And in most cases, now these are the lower level facilities where you find that, we have challenges with human resources. So it is acceptable to have an IPC focal person at this level who does the IPC coordination. But we encourage that all facilities should have IPC committees to work as a team with a representative from every department. Now, let us go into depth. When we talk about the National IPC Advisory Committee, or what we formally call NIPCAC, what is it all about? So this is a committee that is in charge with the responsibility of overall policy, strategy, and guideline development for IPC services, for healthcare services in the country. And at this point, I will let us know that we have the National IPC Guidelines. The first edition was developed in 2010. Then the second edition was developed in 2015. And the third edition is going to be reviewed this year with support from USAID MTAPs. Then we also have the IPC policies, and we have the IPC strategic plan. Now, the IPC policy and the strategic plan were actually reviewed this year, last month, and we are hoping that probably in the next 1 month or so, they should have been approved in AFIA House and, availed to the different professional associations. Then we have the committee that is now chaired by the Director General for Health, and it brings together heads of directorates, the departments, and other relevant programs and development partners supporting IPC. I happen to be a member of NIPCAC, and we have a representation from other organizations that also support the Ministry of Health to ensure that the IPC policy, the strategic plan, and the guidelines are in place and that they are well updated. Then we have the National IPC Technical Working Group, and this is a team that is charged with the responsibility of evidence gathering and synthesis to inform the National IPC policy and the strategy. And the team plans, monitors, and evaluates the National IPC program. So at this point, I will let us know that the National IPC Advisory Committee and the National IPC Technical Working Group, they meet once every quarter. And during those meetings, like I mentioned, we have different stakeholders who work together with the Ministry of Health to ensure that IPC programs and activities are updated and that they are ongoing. Then the National MOH IPC program is charged with the responsibility of coordinating IPC implementation, including developing the training materials and SOPs for IPC services in Kenya. And actually, this office is called the Patient and Healthcare Worker Safety. It's an office and it is there, and it works hand in hand with an AMR secretariat to ensure that AMR is contained using the IPC interventions. And the program also provides technical support to the counties on IPC matters. And I know last month we had we developed the national IPC curriculum that has about 19 modules. So we already have the PowerPoint presentations and modules that cover different components of IPC, from hand hygiene, waste management, occupational safety and health, and so many others. And the curriculum has been divided in 3 tracks. There's a portion for leadership and management. If you want to sensitize leaders on IPC, what are we supposed to inform them so that they can be able to support when it comes to implementation? Then the second track is for the professional and the technical staff like us now, and it has different modules that, you know, what is the healthcare worker supposed to know when it comes to IPC. Then we have the third track that is now for the supportive staff and, you know, cleaners and, you know, people who may not have very good understanding when it comes to technical matters. And now there we have, you know, basic IPC modules like hand hygiene, waste management, and even occupational safety and health that is relevant for them. So the curriculum was developed. We already have a draft, and it was recently shared with stakeholders. We are hoping to get the inputs by Friday this week, and probably we can share with Bao the draft so that we can also get your inputs and incorporate them before the documents are validated. Now, I have talked about the National IPC Adversary Committee. I have talked about the National IPC Technical Working Group. Then we've said we have the National MOH program that is called the Patient and Healthcare Worker Safety. Now we are going to go to the county. At the county level, we have the County IPC Advisory Committee, what we normally call the CIPCAC, and the committee is charged with the overall responsibility and coordination of the IPC within the county. It is chaired by the County Director for Health and is comprised of designated members of the County Health Management Team, what we normally call THMTs. And the County Department for Health will appoint a county IPC focal person who will coordinate the IPC activities and shall be the secretary for this committee. So currently we have about, let's say, 20 IPC committees at the county level, and we are working together with other counties to ensure that every county has a county IPC advisory committee. This is the team that is going to provide overall supervision of IPC activities, both to the sub-county IPC committee and also at times at the facility level, and also to ensure that people are trained as far as IPC is concerned. We have very active committees. For example, in Nyeri has a very active CIPCAC. Kisumu is also coming up with their own focal person and also ensuring that there's a team that coordinates IPC activities. And both of these counties have actually even participated in support supervision. They are able to supervise their own and even give us a report as MTAPs. Now, at the sub-county level, we have the sub-county IPC coordination, and the sub-county health management team shall designate an IPC focal person who shall coordinate IPC matters at the healthcare facilities within the sub-county. Now, at the hospital level, that is between level 4 to 6, we should also have an IPC committee that is chaired by a senior clinical member of the institution with background knowledge on IPC. The membership is multidisciplinary and at the level of decision making. Now, what do we mean when we say this? It means that every department within the hospital should have a representation when it comes to the committee. And this includes the mortuary, it includes the kitchen, it even includes the drivers who drive the ambulances, because IPC is very holistic. IPC is not about the ward, it is not about the laboratory alone, it is about every single department within the hospital. And the committee is charged with the responsibility of planning, budgeting, implementation, and monitoring of all IPC interventions at the facility level. The IPC coordinator will be the secretary of the committee. Now, at the facility level, that is level 2 and level 3, we have the facility health management team who shall appoint an IPC focal person to coordinate implementation of IPC activities at the facility level. However, if the facility has more than 5 departments, then a representative from each of these departments should come together and be able to form an IPC committee. And they can also seek guidance from the high-level facilities on how to do IPC implementation. Now, when it comes to all this committee, apart from the IPC coordinator, we also have the IPC chairperson, we have the IPC secretary, and we have the members. And the members now are what we have mentioned are represented in every single department within the hospital. Now we are done with the structures of IPC, and I started with the National IPC Committee. We then talked about the National IPC Technical Working Group. We went ahead and said that we have an MOH program. We went to the county and talked about the County IPC Adversary Committee. We went down again and talked about the County IPC Committee. Then after that, I scaled down and went to the facility. I said that we have the Hospital IPC Committee, and then finally the IPC Focal Person in facilities that don't have a lot of staffing. Now, we have documents that guide us on implementation of IPC. Like I mentioned before, we have the IPC policy. We also have the IPC guidelines, and the IPC program and practices are guided by this set of documents, and each document is specific and plays a unique role on the guiding of IPC programs and practices. And so the Kenya National IPC Policy for Healthcare Settings, the purpose of the policy is to set minimum national standards for the effective prevention and management of healthcare-associated infections, community-acquired infections, and an antimicrobial resistance. The policy provides guidance for health administrators, healthcare providers, and all stakeholders in observing these standards. So this document is online. If you want to get a copy, just take a photo shoot of this link and you'll be able to get the document. So I'm giving us 2 seconds just to take a photo shot of this link so that you can be able to have your own soft copy. All right. Now we have the National IPC Guidelines for Healthcare Settings 2015. This is the 2nd edition, and the guidelines are developed to improve decision-making by providing guidance and recommendations according to the best available evidence or procedures on preventing healthcare-associated infections and community-acquired infections. Now, you can see here we are introducing community-acquired infections. It is because in the past we have seen we are putting so much emphasis on healthcare-associated infections, and we are forgetting that the infections that are acquired when people are in the community. So we have ensured that the document that we have reviewed also have a component of community-acquired infections and how best to be able to eradicate them. And these documents are intended to act as a central reference point for all healthcare facilities, healthcare providers, and the community, and the link is there. Now, how best do we implement or actualize the IPC guidelines and the policy? We have the Kenya National IPC Strategic Plan for Healthcare Settings that runs from 2020 to 2024, and the strategic plan communicates the national IPC goals to all healthcare stakeholders and provides a framework to develop and implement guidelines and SOPs in order to establish a culture of safety in healthcare facilities. So the strategic plan will be able to tell you how to be able to implement the key indicators of IPC, what you need to do to be able to ensure that they're implemented and to ensure that you have deliverables at the end of the day. So this is how the document looks like. You can be able to click on this link and the document will pop up. Now, one common thing that you see in almost all these documents, they have the same cover page that has the African map. But again, now when it comes to the writings, each document is distinguished. Now, the SOPs are also there for IPC, and they contain step-by-step instructions on how to perform a routine IPC procedure, and they explain the procedure being described. This helps the healthcare workers to carry out routine operations in the most effective manner and also in a standardized way. For example, on the bottom left side, you can see an SOP on how to prepare 0.5% chlorine solution from liquid bleach. On the right side, we can see a chart on COVID-19 outbreak facility screening. We can also see another chart on the right side on how to don and doff the masks and the respirator. So basically, they provide step-to-step guidance on how to implement different components of infection prevention and control. Now, a job aid is a signed worksheet or rather object, which includes diagrams or a brief summary of instructions such as a checklist, and they're designed to be able to reduce avoidable mistakes by helping a person remember what to do or to be sure that they have completed their task and how they were supposed to have been completed. So we have common job aids, for example, on hand hygiene on the left side. We have job aids on, 5 moments of hand hygiene and even segregation of medical waste. They normally serve as a reminder to healthcare professionals. Now, we have talked about the structure of IPC, but we might be asking ourselves, for me to be able to establish an IPC program, what do I need? We have a minimum requirement, and this includes you need to have trained and skilled healthcare personnel who have been trained on infection prevention and control, and the trainings are there. Currently, we have over 1,000 healthcare workers who have been trained as TOTs on infection prevention and control, and specifically Mel Organization, USAID MTAPs has trained TOTs in Nyeri and Kisumu, because these are the counties that we support. But with the Ministry of Health, we also have TOTs in other counties. Then we also need to have information and dissemination platforms for IPC. For example, this is one of the platforms that we are using as USAID MTAPs to be able to reach to other professional associations. We also need to have architectural designs for healthcare facilities for ease of implementation. And this cannot be done without financial and other resources, including but not limited to hand hygiene commodities, for example, alcohol-based hand rub and soap, waste management commodities, those are waste bin liners and incinerators, personal protective equipment, for example, gloves, masks, and others, and vaccination of healthcare workers, especially against hepatitis B diseases. And so we actually have a document that can provide more information. We can see there's a link here. WHO has provided a guidance document on what we need to be able to set up IPC programs in our healthcare facilities. Now, they normally say what cannot be measured is not successful. And so we need to do monitoring and audits of IPC practices and feedback. And we have what we call the Ipc Audits, which is an activity performed to evaluate how well a facility or clinical area is complying with the Ipc standards. And audits help to identify gaps and put up mitigation measures. And we normally have checklists that we can actually share with PSK to be able to help you do audits within your facilities and even at the pharmacy level. This includes WHO hand hygiene checklist. We also have the infection control assessment toolkit, what we commonly call ICAT, and together you should also provide feedback. So what are some of the practices that you are able to audit? We are able to audit healthcare-associated surveillance, and this is an area that as a country, we have not been performing very well. So partners have come together to be able to harness this area to ensure that we have national data on surveillance and that we have facilities supporting these and doing audits at the facility level so that we can be able to see which areas do we have challenges when it comes to healthcare-associated infection. Is it CLABSI? Is it surgical site infections? Then we also have, we can audit hand hygiene, waste management, injection safety, and IPC infrastructure audits. Now, one thing that we always forget when we do audits is to be able to provide feedback to the healthcare providers, stakeholders, and the facility management team. And definitely monitoring of IPC practices provides a systematic method to document the impact of IPC programs using defined indicators. And so this is what we normally call, continuous quality improvement, CQI, which we have also applied when it comes to our implementation. So in summary, as far as IPC coordination and management is concerned, this is an active standalone IPC program with clearly defined objectives, functions, and activities should be established for the purpose of preventing healthcare-associated infections and combating AMR through IPC good practices. And by the way, the purpose for this webinar is also to fight antimicrobial resistance. We have the National Action Plan for AMR that has about 5 strategic objectives, and one of the strategic objectives is on implementation of IPC. So as we continue doing these webinars, as we continue educating healthcare professionals, what we are doing, we are implementing the National Action Plan for containment of antimicrobial resistance. And the existence of a national IPC program and team with a clear mandate will enable the prioritization and implementation of other IPC core components according to the local context and baseline and regular assessment. IPC education and training should be considered during the establishment of a national IPC program for effective implementation of the national IPC guidelines. And like we have just said, monitoring and auditing of IPC practices provides a systematic method to document the impact of IPC programs using defined indicators. And so all this information that we have shared this morning can be able to be received or gotten from these references. We have the WHO minimum requirements for IPC programs. We also have the national IPC guidelines and the interim practical manual for supporting the national implementation of core components of IPC. So thank you so much for listening, and over to you, Mr. Mbao.
Asante for joining for your elaborate presentation. Doris, thank you very much for that. We now we'll request our members. I will request our members to kindly, if you have questions, kindly put your questions on the Q&A tab below there. And so, members, we're going to move to the next presenter for the morning, because it's still morning. Our next presenter is Jemima Katama. She is the IPC lead coordinator. She works at the Kenyatta National Hospital, and then she is the IPC lead coordinator at KNH, and also the National Nursing Association of Kenya IPC coordinator. And she was part of the development team that came up with the curriculum for IPC. She's going to take us through hand hygiene in healthcare facilities. Jemima, are you with us?
Yes, I'm with you.
Over to you, Jemima. To remind our attendees and our distinguished guests, kindly remember to write your questions on the Q&A section. Currently, no questions, so we are waiting for your questions all to be handled after these. Asante. Jemima, over to you. You can take us through now.
Morning, everybody. Thank you, Gitao, for that introduction, and also thank you, Angeline and Doris, for laying the foundation for the other presenters. Because in infection control, you need to have the standard precautions that Angeline took us through. And hygiene is one of the standard precautions, and actually the cornerstone of all the other standard precautions. Before you embark on the other standard precaution, you need to practice hand hygiene. If just to give an example, before you don the PPE or the personal protective equipment, you need to have clean hands. So the standard precautions have their base also in hand hygiene. So welcome for this session. I'm going to take around 30 minutes to go through it. So we have our learning outcomes. By the end of the session, we shall be able to explain the role of hand hygiene in healthcare-associated infection prevention, apply types of hand hygiene technique in healthcare setting, describe the right time and the right way to perform hand hygiene, describe how to evaluate the program, the hand hygiene program, describe the strategies for improving hand hygiene practices in our healthcare setting. Now, just to introduce, sorry for that. Hand hygiene refers to washing your hands with soap and running water or using alcohol-based hand rub, ABHR, with the aim of removing visible soil, dirt, and also removing or killing the microorganism. Healthcare facilities should institute a comprehensive hand hygiene program aimed at changing the hospital structure by making it second nature for staffs to clean their hands before and after every patient contact. What is the role of hand hygiene? Is to reduce the transmission of harmful microorganisms and dirt on our hands and prevent transmission of and microbial resistance. It is the leading measure for preventing and reducing healthcare-associated infections and also the community-acquired infections, as you've had Doris introduce to us we are also concerned of the community-acquired infections. Now, what are the benefits of practicing hand hygiene? One, it reduces the number of patients acquiring infection or healthcare-associated infections. It also minimizes the wastage of resources, like when somebody is paying the hospital bills and buying medicine, all that. Saves lives, reduces healthcare costs, and improves economic output. Let's see the types of hand hygiene. We have routine hand washing, which involves hand washing with soap and water and running water. It is done on arrival at workplace, before and after handling food, eating or feeding patients, before and after nursing a patient, e.g., like bathing a patient or bed making or another procedure, before and after gloving, before and after visiting a toilet, or when hands are visibly soiled. We have 3 elements for hand hygiene. These are supposed to be practiced whether using the soap and running water or Ipc. Friction. We need to apply friction to dislodge the microorganisms from our hands. Timing. If one is going to use soap and water, you need to spend time doing the friction. That is around 45 to 1 minute, 45 seconds to 1 minute. And if you're using the Ipc, it's 15 to 30 seconds, or depending on the manufacturer's instruction. With the third element is about the technique. The technique is very important because we need to cover all the services of our hands. Here is a poster, a job aid, just showing us how to hand wash. Saying that we start with the getting to wet our hands with running water, then get the soap, rub all the surfaces of our hands from palm to palm until the last step. The last step here is about drying our hands, because we know that wet hands can pick that very fast. So the last step will be drying our hands so that we can glove or go embark on the next procedure. Alcohol-based hand rub. This refers to the use of alcohol-containing preparation. It could be a liquid or a gel or a foam designed for application to the hand to inactivate the microorganisms or temporarily suppress their growth. Let's see the characteristics for Ipc or hand rub. First, it kills over 80% of the microorganisms from our hands. Takes around 15 to 30 seconds to dry, so it's easy to use and quick to perform. It's effective when you use around 5 to 5.5 to 5 mils solutions and let it dry before you embark on the procedure or wearing the gloves. We say that it will help prevent growth of microorganisms for a period of time. Contains a small amount of emollient, such as glycerin or any other kind of emollient to prevent our skins from drying. So there's an NB here. We are saying that Ipc should not be used when hands are visibly soiled. Instead, we should use soap and running water. So visibly soiled hands, one should use soap and running water. We have a job aid here, or a poster, demonstrating to us how we should do the hand rub. Just like the hand hygiene, we started with wetting our hands. Here we are starting with pouring or putting the Ipc on our hands, then rub all the surfaces of our hands until the last part of it. The point to note here, with the Ipc, you don't have to wipe or to rinse. You let it dry on your hands, then you glove or go to the procedure. We have surgical hand scrub. This is a systemic hand washing of nails, hand and forearms before undertaking a surgical procedure. Must be performed by all surgical personnel before performing any surgical procedure. We are saying we're going to scrub for 2 to 3 minutes, including the wrist, the forearm, and we should also clean the nails. Sterile single-use towels are going to be used to dry the hands thoroughly, or disposable paper towels. We have a job aid here demonstrating to us how we do the hand scrubbing, surgical scrubbing. Start by wetting the hands just like the others. Pay attention to the nails, to the arm. And the last one here, we are talking about rinsing thoroughly, rinsing even the forearms. And the last one is drying the hands with a disposable sterile towel or disposable hand towel. Now, for the indications for the hand hygiene, we have the 5 moments of hand hygiene. 5 moments for hand hygiene are geared towards preventing the hospital-acquired infection or healthcare-associated infection. These are the moments or the indications for hand hygiene. Before touching the patient, that is moment 1. Moment 2, before a clean or aseptic procedure. After body fluid exposure, risk. After touching a patient or after touching the patient's surroundings. Let's see the introduction of the 5 moments for hand hygiene. We are saying that the 5 moments for hand hygiene describe the fundamental reference point for healthcare workers in a time space framework and designated the moments when hand hygiene is required to be effectively disrupt the microbial transmission of the microbial transmission during the patient care. So the sequence will disrupt the transmission. There's a reference down here. You can note it such that you can also refer for the 5 moments for hand hygiene. Let's see moment 1. What is moment 1 referring to? Cleaning our hands before touching a patient and when approaching the patient. Why do we need to do this? To protect the patients from the harmful germs carried on our hands. We know that we have the microbial flora in our hands, so we need to protect our patient from that. Moment 2 is performing our hand hygiene before clean or aseptic procedure. This is to protect the patient against harmful germs, including the patient's own germ entering through the body. For example, when you're fixing a central line or when you're injecting a patient or fixing a catheter, that is how to protect our patients from the germs. We need to wash our hands. Moment 3, it's about after body fluid risk exposure, that we need to clean our hands as soon as a task involving exposure risk to the body fluids has ended or before gloving. This is to protect the healthcare worker and the environment. Remember, if we don't wash our hands after the procedure, we contaminate the environment at the same time. Moment 4 is after touching the patient. Clean your hands after attending to the patient. Touching any object or furniture in the patient's immediate surrounding, or even when leaving without touching the patient. This will protect yourself and the healthcare environment against the germ. Remember, even when you've not touched the patient, you've touched the door. You may find a patient who has got screen, you've touched the screen or the bed rails. So we need to wash our hands or sanitize our hands. The last moment is moment 5. Talks about washing our hands after touching the patient's surrounding. We need to clean our hands when leaving the patient's surrounding and the immediate surrounding of the patient. This is to protect the healthcare worker from the harmful germs which could be harbored in the patient care environment. We are going to see the patient care environment in the next slides. But before that, let's see a poster or a job aid demonstrating to us about the 5 moments of hand hygiene. Before touching the patient, we've talked about it. Before clean or aseptic procedure. Number 3 is after patient body fluid exposure, after touching the patient, and after touching the patient's surrounding. The previous presenter, Doris, told you, you cannot say you are doing something unless you measure how well are we doing it. So when we are auditing the adherence on hand hygiene practice, we follow the 5 moments. Whether the healthcare workers are going to wash their hands before touching the patient, and the 5 of them. So this is globally the tool we use for auditing hand hygiene adherence among all the healthcare workers in the healthcare facilities. Here we have a video. When you click in between the icon there, you'll see the video on other times where you can wash your hands, apart from the 5 moments. And it will also demonstrate well on the 5 moments of the hand hygiene. So when you get this slide through your email, you can go through the video and learn more about when to wash your hands. Is it before you enter the room or after entering the room? Like when you wash your hands or you sanitize your hands before entering the room and you touch the doorknob, you need again to sanitize inside. So this will guide you even where to fix your ABHR bottles. Let's learn about the zones in the healthcare setting. We have 2 zones, the patient zone and the healthcare worker zone. The patient zone, we are saying it refers to the following: the patient, immediate surrounding services that are touched by or in the direct contact with the patient. For example, the bed rails, the bedside tables, bed linen, tubing, drip stand, and all other equipments which are within the patient reach. The healthcare worker zone contains all the services outside the patient. They include the patient and their zone and the healthcare worker facility environment. So conceptually, healthcare zone is contaminated with the microorganisms that could be foreign and potentially harmful, either because they are drug-resistant organisms or they are the transmission might resort to exogenous infection. When you look at this illustration here, the one which is circle or circular demonstrates the patient zone, and whatever is inside that patient zone, that is the patient zone, and the outside one, the oval one is the healthcare worker zone, away from the patient zone. So we are saying, let's differentiate the 2 zones, and when you leave from one zone to the other zone, you need to perform hand hygiene. We have tips here in hand hygiene, and we are saying that gloves do not replace the practice of optimal hand hygiene. Because if you wear your gloves when your hands are dirty, they're still dirty, they cannot be clean. So you need to wash hands. Avoid hand washing immediately after using ABHR. Let hands dry completely before putting on gloves. When it comes to allergies concerning the ABHR products, you can use an alternative product. Like if you have Proexdin or another or soap and water, you can use that. We should keep our nails short. We are given an example here of 0.5 centimeters. Then remove our jewelry before performing hand hygiene. Because if we don't do this, we're going to contaminate them, and maybe we cannot wash them. Like if it's your watch or your ring, you need to remove it before hand hygiene. Let's see some obstacles to hand hygiene and their solutions. On the left side, we have the obstacles and the solutions on the right side. The first one is healthcare workers saying they're too busy to wash their hands. So what can we do to mitigate this? It is essential that we make time for hand hygiene. Because if we don't make time for hand hygiene, we are going to have the repercussions of getting osteoacquired infections. Skin irritation, we said we can use alternative products. If you react to one product, try another product. Irrational glove use, we should wash our hands instead of wearing the gloves, because the gloves will not substitute the purpose for washing hand hygiene. So hand hygiene is not at the top of the mind. So we should, there's need to become as spontaneous as using aseptic technique and all other safety strategies to improve hand hygiene adherence, and also to remind our healthcare workers to wash our hands. The hospitals should facilitate hand hygiene adherence by fixing or supplying the commodities which go along with hand hygiene, like providing the soap, the paper towels, the ABHR, such that the healthcare workers will be able to wash their hands. When Doris was starting a topic, she talked about administrative support. So the administrators are very key when it comes to hand hygiene. I mean the manager in charge, because they will facilitate the facilities which are required for hand hygiene. So when it comes to cold water or cold weather, use warm water, but even cold water with the right technique and using soap and water is quite effective. Let's have some strategies to improve hand hygiene compliance. We need to increase the availability of the hand sanitizers and also the point for hand hygiene washing. Implement a banding system, reminding each other to wash hands. Place signs or posters near the sink and also the sanitizers near, such that they can also remind our healthcare workers to wash our hands. Internal reminders at workplace are key tools to prompt and remind healthcare workers about the importance of hand hygiene and the appropriate indication and technique for the hand hygiene. You can have every morning before you start work, one of the staff to remind the other staffs about the importance of hand hygiene, or just to remind ourselves, let's wash our hands before touching the patients. We are saying that other strategies for improving hand hygiene compliance, we should embrace the system change, referring to a system approach to ensure that all healthcare facilities have the necessary infrastructure in place to allow healthcare workers to perform their hand hygiene. And I've talked about this, it's about the equipment and the facilities that will encourage somebody to wash their hand. And especially the drying facilities are usually forgotten. Training and educating healthcare workers on the importance of the hand hygiene, including the 5 moments and the correct technique. So evaluation and feedback is quite important. Evaluation and repeated monitoring of a range of indicators reflecting hand hygiene infrastructures and healthcare workers and hygiene compliance. Knowledge and perception is a vital component to enhance hand hygiene compliance. Hand hygiene assessment and evaluation tools exist. You can see the link below there. If you click there, you're going to get the tools. And I talked about one tool, the most important tool about hand hygiene adherence. It's about the 5 moments for hand hygiene. But we also need to have the facilities also. Do we audit the facilities? Are they available to ensure that healthcare workers can practice hand hygiene? This is a research which was done showing the most frequent missed areas and also insisting on the need to use the right technique. When you look at the tips of the hand are usually left because they are the dark areas showing the most frequent missed areas if we don't use the right technique. The other parts, it's the frequent missed areas, and less frequent missed, they are the lighter parts. So we need to employ the use of the technique such that we can cover all the services of our hands. In summary, hand hygiene program components should include education of the staffs, patients, and visitors. We need also to have all the healthcare workers. Most of the time, hand hygiene education is given to clinical healthcare workers. We need to include everybody. The security people, the mausoleum people, people working in the laundry, all the healthcare workers. We should ensure hand hygiene facilities are installed and many sanitizers are fixed in the hospital such that they can remind the staffs, even when you see the sanitizer order, to remind somebody to wash their hands. Recruit hand hygiene champions in every ward department to serve as a reminder to the peer workers. And then we should have regular observation, monitoring, and feedback to healthcare workers on performance. Because if we audit on hand hygiene adherence and we don't give the feedback to the staffs or to the healthcare workers, they may not improve. But when you give the feedback, they may target now to improve from where they've reached. Also, giving incentives and rewards based on performance, maybe the best performing unit or individuals. This will help us improve the hand hygiene adherence. Discussion here. What is the overall hand hygiene compliance rate in your hospital or in your facility where you work, in your department? Maybe you can go now from here and do it, and next time you'll be able to answer that. You'll be able to share with us what is the adherence. Please share your experience with hand hygiene place work reminders. What has worked well, what has not worked, what types of reminders or promotion, how frequent is direct observation of hand hygiene compliance performed at your facility? Is it monthly or after every 3 months or yearly? So we need to share that. We have some references here which can give us more information about hand hygiene and also the tools for conducting hand hygiene audit. So thank you very much. I would stop there and usher the next speaker. For the questions, we shall respond to them after the presentation. Thank you for listening, and thank you for having time to attend to this webinar.
Asante Jemima Katana for your elaborate and deep presentation. We move fast to our. I can see people are responding to the Q&A. Kindly, I request all our attendees kindly pass your questions to the Q&A section, so that we're going to be able to go through them after these. We move to our next speaker for today. Our next speaker for today is Hadija Lelei. She works for the Ministry of Health. She's an environmental health and safety officer. She works with the division of occupational. She works in the division of occupational health safety at the Ministry of Health, and she was part of the team that developed this module for IPC control. So without further much ado, ladies and gentlemen, let me call in Hadija. Hadija, wanisikia?
Yes, please, I can hear. Can you hear me? Can you hear me?
Yes, I can. Take us through the next part of our presentation, Hadija. Karibu sana.
Yeah, good afternoon, participants and my fellow panelists. As we go to the next module 4, we're going to just have an overview on occupational health and safety for healthcare workers. And we'll start by saying that occupational health and safety in Kenya dates back to 1950 with the introduction of the Factories Act. In 1990, it was amended to Factories and Other Places of Work Act, so as to enlarge the scope. And it's been there, only that most people are not aware of the act and how to go about it. So Doris, please project. Okay, thank you. Thank you very much. Yeah, you can put on slide mode. So by the end of this module, we want participants to describe the concept of occupational health and safety, identify potential hazards and control measures at workplaces, identify biohazards since we are in the health fraternity, and control measures, and also explain the legal aspects relating to occupational safety and health. So there's an act called Occupational Health and Safety Act 2007. It provides for the health, safety, and welfare of persons employed and all persons who are lawfully present at workplaces and related matters. So the importance of OSH practices is that it is important for the well-being of both employees and the employer, because this is our workplace is a place we spend most of our hours. Some spend even 10 to 15 hours in a workplace. So we would not want to lose life out of your occupation or to suffer permanent disability out of your occupation. Yeah, next. So it is occupational health, according to WHO, is defined as promotion and maintenance of the highest degree of physical, mental, and social well-being of workers in all occupations by preventing departures from health, controlling risks and the adaptation of work to people, and people to their jobs. So there are basic concepts that we need to understand when it comes to occupational safety and health. First, you need to understand an hazard in your workplace. It is a situation or an act with a potential for harm in terms of human injury or ill health, or both combination of this. Another concept is risk. It's a combination of the likelihood of an occurrence of a hazard or event. Then a key component in OSH is risk assessment. It's the process of evaluating risks to workers' safety and health from workplace hazards. Safety is defined as a state of being safe. It does not really, somebody else may feel safe in a certain place and somebody else may not feel safe. So it is a feeling. It is like, what do you feel? Are you safe? Do you feel safe? So health is in relation to work and indicates not merely the absence of disease or infirmity. Next. Other concepts are occupational diseases. These are diseases that we contract as a result of an exposure over a period of time to risk factors in our workplace or during a work procedure. Then work accident is a discrete occurrence in the course of work, and prevention are all steps or measures taken or planned at stages of work in undertaking to prevent or reduce occupational risks. So what are the potential hazards and control measures at workplace? They are very different depending on where you are. So we have the biological hazards. Most of the health practitioners are exposed to this. These are, they include viruses, they include bacteria, insects, animals that can cause adverse health impacts. For example, mold, blood, harmful plants, sewage, dust, vermin, and even human beings. When your colleague is doing something that can cause a hazard, can be categorized there. Then we have chemical hazard. These are hazardous substances that can cause harm. These hazards can result in both health and physical impacts, such as skin irritation, respiratory irritation, blindness, corrosion, and explosions. Then we have physical hazards. These are hazards, environmental factors that can cause harm to an employee without necessarily touching them, e.g. heights, we have noise, we have radiation and pressure. Then there are also mechanical hazards, more or less like the physical hazards. They create unsafe working conditions. For example, if you have exposed wires, if you have a damaged carpet, which can make you trip, it may include, as I said, it may cover also the physical hazards. Then we have ergonomics. Ergonomic hazard is as a result of physical factors that can result in musculoskeletal injuries. For example, a poor workstation setup in an office, a poor posture while handling things, maybe lifting up things. Also some kind of chairs that we use at our workplace that you're not able to have a correct posture can cause ergonomic hazards. Then you have psychosocial hazards, include those that can have an adverse effect on an employee's mental health or well-being. For example, sexual harassment, victimization, stress, and workplace violence. Yeah, one of the ergonomic hazard I would say in the pharmaceutical industry is most of our pharmacists sit in this high stool that it's called Sinatabu. But the back has a lot of problems if you're using that kind of a chair in your workplace. Thank you. Next. So ergonomic is a way of designing workstations, work practices, and workflow to accommodate the capabilities of workers. Ergonomic design reduces risk factors not to contribute to occupational injuries, such as sprains and strains and accumulative trauma disorders. If work is performed in awkward posture or with excessive effort, fatigue and discomfort may result. Under these conditions, muscles, tendons, and ligaments and blood vessels can be damaged. Injuries of this type are known as musculoskeletal disorders, and it is recognized in the Occupational Health and Safety Act. So since hazards exist, we need to reduce them, and there are ways we can control these hazards. Number one is that we need to eliminate so that there's no hazard in our workplace. This is the most effective control involving elimination and removal of danger. This can be done by changing a work process in a way that will get rid of a hazard, or substituting a toxic chemical for a less toxic, or having workers perform tasks at ground level rather than working at heights, and other methods that can remove a hazard altogether. Then also you can substitute a hazardous substance with a non-hazardous or less hazardous substance, or even processes. There are risky processes you can substitute with less risky. Then we have engineering controls. If a hazard cannot be eliminated or a safer substitute cannot be found, the next approach is to do engineering controls. A good example is what we are doing now with the COVID control, where we are stationing people at 1.5 meters apart, also introducing openable space in our rooms so that we have enough air circulation. This air circulation is called, when you introduce more openable space, this means you are having something called behavior change enabler. This will enable you maybe stay with a mask because there's more air circulating in your room other than staying with in a conference or in a room where there's no circulation. So engineering controls can vary depending on your workplace. Then we have administrative controls. If engineering controls cannot be implemented or cannot be done in the right way, then administrative controls can be done, which involves putting policies that will make sure hazards are reduced in our workplace. It includes things like warning alarms, labeling systems, reducing time for workers of exposure, job rotation, and many other ways that we can make sure that an employee is not exposed to a hazard. Then we have a personal protective clothing. It is considered the least effective, not because it is not effective, but in the ideal situation is that there should be no hazard in your workplace, because this is a place where you are working. But when in the event that the hazard is not eliminated, then we have to use PPE. Well, like in the case of COVID, this hierarchy would put PPE as the first, then as we continue with the rest. Next. So this is just the hierarchy of hazard elimination in our workplace. We first eliminate, then if not possible, we substitute. If not possible, we do engineering controls to remove the hazard. If not possible, we do administrative controls. If not possible, we do PPE. But what has happened this 2020 is that this hierarchy has now gone upside down. Yeah, next. Yeah, then we need to identify a part of risk assessment in occupational health and safety is identifying what are the hazards in our workplace. Specifically for a healthcare worker working in a facility, biohazards are the common hazards that you'll find. So let us look at them. So we have biological hazards. They exist in all healthcare settings. You can eliminate, but this kind of hazard will come because the nature of your work there is to see patients who are coming with this kind of infections. So we have TB, we have hepatitis B, we have hepatitis C, we have HIV, and now we have COVID, which has been classified as an occupational disease. So healthcare workers are at risk of infections from either it can be an accidental exposure to biological hazards, then there's need of preventing exposures and management of exposures when they occur. Yeah, next. Then the diseases in the hospital industry, this is also recognized in the Occupational Health and Safety Act. We have hepatitis B, hepatitis C virus, tuberculosis, bloodborne diseases like HIV. We have anthrax, brucellosis, tetanus, and occupational dermatitis. So these are diseases that as a healthcare worker, you are supposed to report. If a patient comes in and tells you maybe got this out of work related, then as a clinician, you're supposed to record and send this to the Directorate of Occupational Health and Safety. And also if you suffer as a clinician in the course of your work because of these diseases, then you're supposed to record and report to the Directorate of Occupational Health and Safety. Next. So screening is a part of controls, and some of the diseases that should be screened for every employee, maybe depending on where you work. So these are some of them: HIV, hepatitis, TB. Yeah, we do screening for ELISA AB, syphilis, and and hepatitis. So management of exposure to HIV and other blood-borne pathogens. So literature says that by 2009, the global burden disease revealed that 5 to 10% of new infections, 30 to 32 of new hepatitis infections, and around 40% of hepatitis C infection in low and middle income countries may be attributed to exposure in healthcare settings, to unsafe injections, unsafe blood, and occupational exposures. So we categorize these if we can say if it's low risk or high risk. For example, if you are exposed and the skin was intact, then that is low risk. Then if high risk is when there's no intact skin or it was a percutaneous injury. For example, if it is the person who exposed to is HIV negative, that is a low risk. If the status is unknown, then you would feel as either high risk. And if the person was positive, of course, now you will still feel as high risk. Then the materials, if it was through saliva, tears, sweat, feces, urine, vomit, then you would feel it as a low risk. But I think for COVID now, for any respiratory like saliva would come this side of high risk. Then for HIV, if it was semen, vaginal secretion, synovial, pleural, pericardial, peritoneal, amniotic fluids, blood and bodily fluids, then these would be considered as high risk. So the risk of transmission of different viruses following accidental needle stick injury, we have hepatitis B is 6 to 30%, hepatitis C is 1 to 8, and HIV was 0.3%. So there are steps post-exposure management. These are 5 steps. First, you need to provide immediate care to the exposure site. That is cleaning if not done. Then determine the risk associated with the exposure. As we have seen in there, if it was low risk, high risk, you need to determine where you think you fall. Then evaluate source and exposed individual. And then choose appropriate regimen and start ARV drugs. This is a case for exposure to HIV. Then document in the PEP register and provide follow-up, testing and counseling. Now, on top of this documentation of a PEP register, Occupational Health and Safety requires that you also document in the accident register. Then, so that in the event you need to follow up for compensation, they'll use the accident register, which is supposed to be in your workplace. So first aid exposure to mucous membrane or non-intact skin. Of course, you flush exposed mucous membranes of eyes and mouth with water. If saline is available, then flush with saline. Then do not use caustic agents, including antiseptics or disinfectants. We know that these are harsh. Then inform your supervisor so that you're released from duties. Then a very key component in occupational health is that there are legal aspects. There are legal aspects to the employer, there are legal aspects to the employee, and there are legal aspects on when and how you need to be compensated. So let us look at that. So according to the Safety Act, we both play a role in ensuring that we are in a safe environment. So we'll start with the employer in your workplace. The role of the employer is to provide a workplace free from serious recognized hazards and comply with standards, rules, and regulations issued under the Occupational Health and Safety Act. Then the employer also needs to examine workplace conditions to make sure they conform to applicable OSHA standards. The employer must make sure employees have and use safe tools and equipment and properly maintain this equipment. The employer also has a role to use color code, posters, labels, or signs to warn employees of potential hazards. The employer must provide safety training. Next. The employer also needs to establish or update operating procedures and communicate them so that employees follow safety and health requirements. The employer must provide medical examinations and training when required by OSH standards. These are very good practice because you're able to establish if the condition maybe the employee is complaining about was post-work, was before employment or after employment. Then you need to post at a prominent location within the workplace, the OSHA poster or the state plan equivalent, informing employees of their rights and responsibilities. And then you need to report to the nearest OSH office all work-related fatalities. This should be done actually within 48 hours. Then you need to keep records of work-related injuries and illnesses for future in case there's a legal issue and maybe for future reference if somebody is seeking compensation. Next. So the employee also has a role in according to the Occupational Health and Safety Act. The employee first responsibility is to ensure his own safety and health and that of other persons who may be affected by his acts or omissions at the workplace. Some accidents may occur because of an omission or an act of another employee, and maybe the employer had done his role. Then the employee must cooperate with his employer or any other person in the discharge of any duty or requirement imposed on the employer or that other person by his act or any regulation according to the act. The employee must at all times wear or use any protective equipment or clothing provided by the employer for the purpose of preventing risks to his safety and health. So in the event the employer has provided the PPE and the employee is not using, so if there's an accident, then this employee should also record, but it should be clear that the employer had done their role. It is only the employee who did not do his or her role by using protective equipments. Next. So the employee must also comply with the safety and health procedures, requirements and instructions given by a person having authority over him or her. Then he should report to the supervisor any situation which he has reason to believe would present a hazard and which he cannot correct. The employee also should report to his supervisor any accident or injury that arises in the course of or in the connection with his work. So these roles and responsibilities are in the Act, and if you either party fail on their part, you can actually do prosecution. Then reporting an accident, staff must report all work-related exposures and accidents that could result in illness and injury, including near misses within 24 hours. All these reports should be reported using a defined and captured in the DHIS form. So there is the one common thing that is in the facility, which is a PEP register. Apart from that, there is a form that specifically for reporting accident and exposures, so that this data is captured and submitted to the Directorate of Occupational Health and Safety. The report should be submitted to the immediate supervisor for approval. The supervisor shall submit the report to HR and county focal person. The county focal person here we mean is the Occupational Health and Safety county focal person. So this will cascade up to the Directorate of Occupational Health and Safety. Then that OSH focal person shall coordinate accident and exposure investigation and ensure that relevant personnel are involved and a report is compiled. Technical support and advice can be sought from the county OSH focal person. The OSH focal person shall submit the report to the county focal person, who should hold a meeting within 48 hours to review the report. Yeah, so I think I've come to the end of my presentation. What is key, colleagues, is that this information should reach as many people as possible, because people are missing out because of not reporting an accident, not recording, which is very key in occupational health and safety. An accident not reported, not recorded. In case you suffer disability, or in case you have in case you suffer death out of that exposure that was work-related, you may lose in your compensation. But let us, I think with my previous presenters that IPC have done well, we may not need to reach this point. So thank you very much.
Asante Khadija for your insightful and it's the new lessons that you're learning today, right from the first speaker. Thank you very much. So, ladies and gentlemen, we move to our questions, to our Q&A section, and I will ask Doris Botter to lead us into that section. Doris, are you with us?
Yes, Bao, I'm with you.
Yes, I'll request you to lead us into the Q&A part, where we're able to respond to the members' specific questions. The first question goes from David Odada. Probably, Doris, you can take it over.
Okay, thank you, I will. So the first question came from Dr. Odada. Thanks for the very informative presentation. We have national guidance on rates for benchmarking our healthcare-associated infections in view of CLABSI, COUTI, VAP, etc. So that's one of the questions which I will take. I would also want to read some of the other questions so that the other facilitators can prepare once I give a feedback. There's a question from Dr. Maua. Comment on the use of hands-free hot air hand dryers. He says again, comment on the use of the hands-free hot air hand dryers. So that question goes to Jemima Katana from KNH. Jemima, kindly prepare to respond on that. Then we also have another question from Dr. Bande. What's the plan on sustainability of your program? Taking into account that programs have timelines, yet we need these to continue even after your program is done. So I suppose that this was meaning my program, that is USAID MTAPs, about the sustainability of it and ensuring that whatever we are doing right now is also able to continue even at time after we have gone. I will respond to that. And then the last question is by Dr. Odada. In developed countries, platforms are developed where healthcare-associated infections are shared for best practices, reimbursement, and quality purposes. What is the status in our country? I read again, in developed countries, platforms are developed where healthcare-associated infections are shared for best practices, reimbursement, and quality purposes. What is the status in our country? So that question goes to Hadija. So allow me to respond to my questions, and then I will be followed by Jemima and then finally Hadija. And we have just about 7 minutes to be able to do that. So for Odada, regarding the benchmarking of healthcare-associated infections in view of CLABSI, COUTI, and VAP, yes, we do. We actually have forms and documentation on the same. But however, tomorrow we have a presentation on healthcare-associated infections in healthcare services that is going to be undertaken by Dr. Leon from the Kenya Medical Associations. We request you to attend that session tomorrow so that we can be able to shed more light on the same. But yes, we do have we do have forms and guidance document in the country. Then there was the other question on what's the plan on sustainability of your program? That is USAID MTABs. I know programs come and they go. We are building the capacity of professional associations. And by the way, what we have presented right now was as a result of an education committee that was formed from 7 different professional associations. That's the National Nurses Association of Kenya, the Kenya Clinical Officer Association, ACAMULSO, that's the Association of Kenya Medical Lab Scientific Officers, the Kenya Society for Physiotherapists. We also had the Kenya Pharmaceutical Association and the Kenya Medical Association. Now, these associations came together and developed a curriculum and about 7 PowerPoint modules. And this is what we've been presenting today. Tomorrow we present the other 3 modules. And all these packages are going to be given to these professional associations associations for continuity purposes. We also plan to train TOTs within the respective professional associations who are going to support us to scale up the same to other regional chapters. Apart from that, USAID MTAPS has trained TOTs at the facility level and in all the counties that we support on IPC, and these are our champions who continue to advocate for IPC improvement, both at the county level and even at the sub-county and facility level. Apart from that, we are working hand in hand with the county health management teams, the county directors, the county ministers for health, to be able to work with them as we do the implementation. And each of the facilities that we have supported has IPC work plans that they normally, with key IPC activities that are supposed to be undertaken. And these work plans came as a result of a baseline assessment that was conducted in all these facilities. At the national level, we are working hand in hand with the National Patient Safety, National Patient and Healthcare Worker Safety Unit that houses the MOH IPC program. And together we reviewed the IPC policy and the strategic plan. This quarter, we plan to review the IPC guidelines. Now that is building the capacity of the Ministry of Health and also to ensure that they have reference documents that they can use for continuity. So we continue working together with all stakeholders to be able to ensure that it is not only IPC, but also antimicrobial stewardship activities are well streamlined, so that even as we live as a projects and programs have a timeline, there's a continuity of activities. And so we have also brought on board the professional associations to be able to drive the process through these activities that we are undertaking. And what we have done today is just part of the implementation package that we are undertaking. So I really hope I have responded to your question. I'm going to request Jemima to respond to the question on hand hygiene, and then Hadija as well. And we only have about now 4 minutes to be able to do that. Thank you, and over.
Thank you for that, Doris. I want to respond to the question asked by Edwin Maua. Thank you, Edwin, for that question. It's regarding the use of hot air for drying our hands. Yeah, according to WHO CDC recommendation on healthcare facilities, we recommend hand paper towels opposed to the hand dryers, because what the hand dryers do, they use the negative pressure. They pull air from the environment, then blow to one's hand. So it has been shown that they blow the microorganisms to one's hand when they are wet and add more. They have also been shown that the normal fluoride from the healthcare worker, from the user's hand, can be blown up to 2 meters, contaminating the same environment. There's also the issue of drying. So if the environment is contaminated and the blower or the dryer is using the negative pressure, it will draw the contaminated air and blow to the wet hands. So according to the recommendation, we'd like to use the paper towels or even other methods than the hot air dryers. Now, there is also another question about hand hygiene, about the kitchen, which was asked by David Odada. David, we have three levels of hand hygiene, and I talked of routine hand washing, or it's usually called social hand washing. Hygienic is the where we have the 5 moments and we have the surgical scrub. So the people working in the kitchen, you look at the social hand washing, the routine hand washing, they're supposed to wash their hands before handling food. And we also have the special kitchen audit tool on infection control, which Doris talked about. Etiquette audit tool, which audits the people working in the kitchen. And remember that that person working in the kitchen, if they don't wash their hands, the food will go back to the patient, and everybody again will be affected by that food. So they need to wash their hands as they arrive to the hospital, before preparing or even handling any food, before and after going to the toilet. So they are not exempted. So everybody in the healthcare setting is supposed to follow the hand hygiene performing, depending on the level at which you are doing it. Even if it's a healthcare worker, if you are not at the patient side, you follow the social or routine hand hygiene. If you are not in data, you are using the 5 moments. Thank you. David, again, you asked about the platforms, and Doris has already talked about that, will be answered tomorrow. But just to tell you that we have IPNET, that is Infection Prevention Network Kenya. This is a platform which is multidisciplinary. All the professionals are together. We share our best practices there, and we normally have our conferences yearly or even, and we have international supporters, the ICANN, that is international, that is Infection Control African Network. We normally have our biannual conferences with them. That's where we can share our best practices. Being one of the founder members, I can give you more information on that. And Doris right now is the secretary for that IPNET organization. You can contact her, she can tell you more information about that. Thank you.
Thank you so much, Jemima, for really responding to the questions very well. Hadija, over to you for the response on the question that had been asked, and we only give you about 2 minutes because of the interest of time. Thank you, and over.
I would answer by saying that we don't have a developed platform for where we can share HIs and best practices, but we have an IPC program at the Ministry of Health, and I think this is a challenge to pick it up so that we, as David Odad has correctly put it, these are things that we need to be able to see. This happened in this hospital, and they were able to address it like this. Then there's a question from Eric, where do we get the standard reporting forms? Within your county, if you ask for the occupational health and safety officers, they should be able to avail them. We'll also share from our office to whoever may need them. Thank you.
Thank you so much, Hadija. And also to build on to what my colleagues have said, we have the National Occupational Safety and Health Policy Guidelines for Healthcare Service Delivery. If you can see the Act, it was developed in 2007, and that is a long, long time ago. And one of the gaps that we saw in the Act is that it was really not speaking so much to the healthcare workers. It was speaking about factories. And so what the Ministry of Health did, they went ahead and developed an Occupational Safety and Health Policy Guideline for Healthcare Service Delivery in 2014. And that document actually also has some of the occupational safety and health forms that Hadija has talked about. So what I will do, I will probably share the link where you can be able to get it online before we close, and also the link for the IPC guidelines and everything else that we had talked about. So thank you so very much for your cooperation. I'm seeing we started with the same number that we have finished with. We are really happy to collaborate with PSK, and we are looking forward to more future engagements. And on behalf of USAID MTAPS, thank you so very much for having us. Thank you, and over to you, Dr. Mbao.
Asante sana, Doris. We highly appreciate. And to do that in my African culture, a young man as myself will not be allowed to say thank you to guests. And to do that, I will welcome a member of the National Executive Committee of the Pharmaceutical Society of Kenya, and that is none other than Dr. Anis Rahimtula, to give us the closing remarks. And before he does that, I want to remind you members kindly to go subscribe on your PPB portal. The CPD points will be sent. We're trying to send all the CPD points for the last 2 weeks by close of business on this Friday. So kindly subscribe to the PPB portal for that. And CPDs are only for valid PSK members. Over to you, Dr. Anis Rahimtula, for the closing remarks.
Thank you, Bao. Thank you for introducing me. Also, thank you to all the presenters. I think the presentations were of very high quality. It's comforting to see some engagement between infection control nurses and pharmacists and farm techs. And I think there's a lot of working together that pharmacists can do with nurses to improve quality of healthcare. The presentations, it was good to have the understanding of the basics and definition, which allow for building blocks. However, the challenge is we might know, but how do we share this information with those who work with us, or those who work below us, or the patients themselves. It is good to put the perspective of other diseases and other organisms besides COVID that also affect information control practices in the country. We should take it as a challenge on us to reduce that 25% of hospital-acquired infections in hospitals. We need to come down to the developed country levels. We have the expertise and we have the human resource ability. We should look into ways of how we'll move that 25% to 6% or 8% that we are talking about. We have excellent structures. I didn't even know some of these existed. It's great to see that they are there. The question we need to ask ourselves is are these structures working? And if they are working, then why is that percentage 25%? The presentations against were very good. We need to know what, from the presentations, what is the reality on the ground. And maybe later on we can do a presentation on theoretical versus reality, and we see where the gaps are. Monitoring and evaluation is probably our greatest challenge. To say that we prepare good papers, but how are we going to monitor and evaluate that this work is still being done correctly? I'm glad that one of the positive things that have come out of COVID is more and more people have learned how to wash hands. If you look at videos on hand washing, they are now viewed in the millions of times, so that everybody now knows how to wash hands and how to wash hands correctly. So when you ask yourself how long is 15 to 20 seconds, most people will tell you it's like singing happy birthday. So every time you wash your hands, you say happy birthday, you sing happy birthday, and that's how you get your 15 to 20 seconds. The OSHA presentation was really good. My only question is that how applicable is it in public hospitals, or is this only for private hospitals? And it's a fitting presentation to put now, especially that we have the doctors and nurses, the pharmacist doctors union is about to go on strike. So with those closing remarks, I want to say thank you very much to all the presentations. The presentations were excellent. However, for continual improvement, it's always good that we check on our processes and see how well they are working, and so that we can better the quality of healthcare. Thank you, and I look forward to seeing all of you tomorrow.
Asante Dr. Aniz. Hatuna budi la kukuaga kwa heri kusema kwamba somo letu la leo limefika tamati. Nitawauliza mwende pale kwenye chat box, mtapata link ya the various safety policies. Have a great evening and God bless. I will end this webinar at exactly 1:05. So kindly go to the chat box and get the links to the safety policy, occupational safety policy. Asante and have a good night.